Hello, and welcome to today's Wounds webinar. Today's presentation is SAM antimicrobial technology and a new solution to help manage both infection risk and pain with SAM PainGuard. My name is Jenny Lamberts for Wounds. We're happy to have you join us today. We'd like to thank Embed Biosciences for sponsoring today's presentation. To the audience, we encourage you to submit questions and comments for our speakers using the question submission section on your screen. At the end of the presentation, we'll try to answer as many of your questions as possible in the time allowed. Today, we are pleased to welcome our featured speakers, Damien Dauphinee, Suhail Sharif, and Gaurav Pranami. Damien Dauphinee is board certified in foot surgery and reconstructive rear foot and ankle surgery by the American Board of Foot and Ankle Surgery. He is also board certified in wound management by the American Board of Wound Management. Dr. Dauphinee has a special interest in reconstructive foot and ankle surgery, trauma, and peripheral nerve injuries. He is a current fellow and served as president of the Association of Extremity Nerve Surgeons in 2009. He serves as faculty for the AENS Fundamental and Advanced Peripheral Nerve Workshops, training surgeons to treat a variety of peripheral nerve pathologies. Dr. Dauphinee lectures nationally and internationally on diabetic limb salvage, hyperbaric oxygen therapy for chronic wounds, and peripheral nerve pathology and treatment. Suhail Sharif is a board-certified general surgeon and a fellowship-trained surgical oncologist in Dallas-Fort Worth, Texas. Specializing in the surgical management of advanced colorectal, hepatobiliary, pancreatic, melanoma sarcoma, breast, and GI tract malignancies, Dr. Sharif is one of the few providers of intraperitoneal hyperthermic chemoperfusion for advanced abdominal cancers with carcinomatosis in the Dallas-Fort Worth area. He also offers local regional hepatic and pancreatic-based therapies using ablative and nanoknife technology. He is an expert in minimally invasive robotic-assisted Da Vinci surgery for the surgical management of cancers. Due to his vast experience with immunocompromised patients, he is also an expert in managing complex surgical wounds. Gaurav Pranami is Vice President of Research and Development at Embed Biosciences, where he directs the design, scale-up, and regulatory clearance of novel bioresorbable wound matrices. He has over 15 years of experience leading multidisciplinary teams in industrial research, product development, and regulatory strategy. His technical expertise spans polymer science, coatings and interface engineering, process scale-up, and advanced wound care technologies. His work has been instrumental in the development and FDA clearance of the company's SAM portfolio, including the latest PainGuard line, which integrates silver and lidocaine hydrochloride to address infection risk and pain simultaneously. We are delighted to have them join us today. Please see the disclosures on the slide for the speaker's disclosures. And with that, I will turn it over to our first presenter, Dr. Pranami.
Hey, thank you, Jenny. And I'm delighted to be here to talk about the science behind our products, to set the stage for our clinicians to talk about how this science translates to clinical care. So let's talk about the challenge, the clinical challenge that we are trying to address. So each year in the US, about 50 million surgical procedures are performed, and about 2 to 5% of these procedures result in surgical site infections. And assuming an average rate of about 3%, that comes out to about 250 surgical site infections per hospital annually. And it costs about $50,000 per patient to address these surgical site infections. So you can see that this is a huge clinical and financial problem. And not only that, according to CDC, surgical site infections keep patients in hospitals for as much as 10 additional days, keeping them away from their family, work, and daily life. And when we look at burns these issues are even more challenging. So infection is a significant and independent predictor of skin graft loss, and nearly 75% of burn patients' mortality is due to infection. And so these clinical challenges highlight the need for smarter wound matrices that protect the wounds and promote healing at the same time. And that is exactly the reason why we developed SAM antimicrobial matrix technology. And so, what is SAM? And as I dive into that, I would like you to focus your attention to the video on the right. In the video, you can see that the matrix was applied to a wound. And as it is applied, it is absorbing the wound fluid and conforming intimately to the wound tissue. I mean, a lot of products out there, they talk about how they conform to the wounds. But microlight, the SAM technology is truly different because it really conforms to the all the nooks and crannies of this, very textured wound bed. So what is SAM? So SAM is an ultra-thin porous matrix made of bioresorbable polymers designed to mimic extracellular matrix. It conforms to the microtextures of the wound bed, kills 99.99% of bacteria and yeast, and resorbs within a week. It can be used from the onset of the wound management and can be combined with other wound management technologies like negative pressure wound therapy. And now, um, with PainGuard, it also delivers pain relief. So let's sort of pause for a moment and talk about why management of pain in surgical wounds is so critical, right? So 86% of patients undergoing surgery report post-operative pain, often in moderate to severe range. And out of those patients, up to 25%, you know, 25% seek readmissions after discharge because of pain. And so if you add to that the fact that often the pain is managed with opioids, and 1 in 10 patients experience opioid-related adverse events, which increases the risk of mortality, the length of stays, and hospitalization cost. So you can see that safe and effective management of pain is an unmet need, and having new technologies and products that can help us reduce the usage of opioids can be really, really helpful to address this clinical challenge. And so to address that, and building upon the success of our SAM matrix, we now have FDA cleared PainGuard matrix. So PainGuard basically adds lidocaine to the SAM technology, making it the first and only wound care matrix that incorporates both broad spectrum antimicrobial silver and lidocaine HCl for management of both the infection risk and pain. The matrix provides a burst release of lidocaine to address the acute pain in a variety of wounds. So, trauma, surgical wounds, burns, but also in chronic wounds. So when patients are undergoing a debridement or dressing changes, this matrix provides pain relief there as well. And the way we have designed it is that it delivers a unit dose of lidocaine and a uniform release, which is comparable to a 4% lidocaine ointment. So The product contains 0.4 milligrams per centimeter square of lidocaine. And over a period of 24 hours, the maximum amount of lidocaine that can be administered is 300 milligrams or 4.5 milligrams per kilogram. And since the dosage is body weight dependent as well, it is important to consult the dosing guide, especially for patients with lower body weights or if they have very large wounds, because excess absorption of lidocaine has serious side effects. So how does SAM really work, right? So we saw the video earlier, and in that video, you noticed because it is designed to be ultra thin, as soon as it contacts the wound bed, it absorbs the wound fluid and it conforms to the wound bed intimately, right? And creates a moist wound healing environment that allows for the cellular growth. And because it is able to conform to every nook and cranny, it helps prevents any voids where bacteria could proliferate from and prevents the pooling of exudate. And the antimicrobial silver in the product is effective at killing 99% of bacteria and yeast that are frequently isolated in clinical wounds. And it provides this antimicrobial activity for 72 hours. So here's a chart that basically shows what I just said. Uh, so it kills 99.99% of MRSA, drug-resistant MRSA and VRE, Staph aureus, Pseudomonas aeruginosa, E. coli, Klebsiella, Candida albicans, and Candida tropicalis. But this effectiveness of SAM comes from how uniformly silver is distributed in the matrix. So if you look at the images on the left, they are transmission electron microscopy images of the matrix from the side and from the top. So you can see how uniformly silver particles are distributed. And so what happens is that once the product is in the wound, these metallic particles dissolve gradually to continuously produce silver ions for 72 hours. And that in turn results in antimicrobial activity, which is sustained for 72 hours. And so as you saw in the video, and as is shown in the schematic at the bottom of the slide, SAM matrix conforms intimately to the wound bed, whereas conventional dressings kind of just sit across the wound. And so because of this conformability, SAM matrix is effective against microbes at 10 to 100 times less silver than conventional dressings, thus making it non-toxic and at the same time effective. So really, what's the advantage here, right? So it's the uniform distribution of silver in the dressing combined with its ability to conform to the wound bed that really creates the SAM's antimicrobial advantage. So managing the risk of infection is one thing, but SAM also delivers a scaffolding effect. Its polymeric architecture is ideal for enabling the native cells, so fibroblasts and keratinocytes, to attach to it and adhere, migrate, and proliferate. And so what that does is it helps promote the healing of the wounds. And because it is composed of bioresorbable polymers, the matrix is resolved within a week. So in summary, SAM is an ultra-thin bioresorbable film that kills 99.99% of bacteria and yeast. And it resolves within a week. And now with PainGuard, it also delivers pain relief. So now that I have spoken about the science behind this technology, I would hand it over to Dr. Sharif to talk about how it translates to the clinical care.
Very good. Thank you, Dr. Pranami. That was excellent. So, you saw the science behind it. You saw the pathophysiology about exactly how it works in the bench and so forth. But what's important as a clinician, as a surgical oncologist who actually deals with complicated cancers and so forth, how is this relevant to my practice and hopefully relevant to your practice as well? Is like basically 2 to 3 aspects here. Number one is, whenever we're dealing with a product as someone who's actually in administrative roles and part of the CVAT committees for the hospitals looking at new technologies, number one you want to evaluate is to make sure the ease of the application, the fact that like the technology delivers and it's an easy process, so you're not having to go through the motions of requiring expertise into it and specialized training into it as well before you're an expert and capable of doing this. That's number one. Number two is that it delivers as promised. As you saw, the SAM technology is very straightforward, very simple. It's a polymeric microbicidal matrix with silver impregnated in it. So if you give that to a tissue that has a high chance of having a surgical site infection, does it deliver to a point that it can apply the silver to that area so it decreases the risk of infection? So that's basically what we're looking at. And especially in my categories of patients, where my patients who as a surgical oncologist who are immunocompromised, that are immunosuppressed, that are malnourished, one of the main aspects of their overall recuperation and especially their outcomes has to do with how soon can they heal so they can get back to further treatment. And ultimately, this will affect their quantity of life as well, their survival. So I've been in the market, obviously, as somebody who has done this for almost like 16 years, looking into products that could benefit my patients. And that's how I came to apply SAM technology in my practice. Number one that you see is the fact that it takes probably, I don't know, maybe 5 to 10 seconds to just rip open the seal and apply the product. So it's very straightforward, very simple, really not much that's needed from it. And number two is the benefit that you get from it, which actually, as clinician and as somebody who's looking at all of these things as well, what you wanted to see is, does it deliver? And I'll show you some pictures and videos of my cases that we have applied and the benefit that I've received. And as you can see, I've used this in more than 100 cases actually. And number one, there's been no significant adverse effects as well that we have seen. And the low and anecdotally, and this is something that we're actually analyzing and hopefully we'll be able to publish it soon as well, is that there is a lower rate of surgical site infection and also seroma formation as well, just because it gets into the nook and crannies of all the tissue. So that way it causes that absorption of the fluid in the wound. So you're not developing a seroma, and especially when you close the wound itself, that you don't have a seroma, that this patient doesn't need to have another procedure to have a drain placed and all that other cost that goes along with it. And an added benefit that I saw was the fact that the wound actually heals faster than you would anticipate it to heal if you did not use the SAM technology. So to highlight how important surgical site infections are in my category of patients is that every hospital has SSI is in one of their top lists as to a mechanism of trying to decrease the risks of surgical site infections in the hospital. They spend tremendous amount of effort, money, organizations and meetings and so forth to look at ways we can decrease the SSI rates on any type of surgical procedures. Unfortunately, as I mentioned, my category of patients are immunocompromised, immunosuppressed, malnourished. So what do I need to do for my patients to evaluate, to see the benefit of SAM technology? One of the things that I use is something called the NSQIP score. NSQIP is basically National Surgical Quality Improvement Program. It's by American College of Surgeons. And what they do is that you can basically enter the kind of procedure that these patients are undergoing and a little bit of risk factors associated with this. For example, this is one of my patients where we're doing a pancreatectomy, a Whipple procedure on them. And then, we include in certain other other risk factors. For example, this patient's 68 years old, she's female, has a certain other comorbid conditions like hypertension and obviously obese as well, like with the BMI of 37. So what it does is by entering these factors, it tells you what is the risk of this patient's chances of developing an SSI. And in my patient for this one, the risk of her developing an SSI is almost 26.6%. You can imagine that 4 Whipples that I do, one of them inevitably will develop a wound infection that's going to prolong their hospital stay and ultimately kind of affect their quality of life as well after surgery, and ultimately delay them requiring any adjuvant chemotherapy and so forth. So this is the milieu or the criteria or the class of patients that I'm dealing with that I would like to see if I can benefit them so that way I can decrease this risk of them developing an SSI to something much better. So that is where I was exposed to SAM technology. And what you see is, number one, in the wounds, I just basically apply it. And then you see how, as Dr. Pranami mentioned, like how the SAM technology, the PelliShield just basically incorporates into the tissue with just light touch. Really, you don't even need to apply any fluid or anything at all. It just incorporates very well. And then we close the skin on top of it. And you could see just within 2 weeks how well the wound heals actually. It heals tremendously, and we have had no adverse effect related to this as well. And what you also see is that like in my category of patients where I'm trying to do some major debulking, this is a patient who has recurrent retroperitoneal sarcoma where I've taken out part of the colon, part of the rectum, part of the pancreas as well. And as you can see, all the different stuff that I removed on this patient, was a very complicated procedure with a very complicated wound. And I had to extend it laterally as well, just because in order to get the big massive tumor. And again, this was a patient that I've done 2 previous surgical resections on about 8 years ago. And another one was almost 12 years ago for recurrent sarcomas, and who inevitably actually did develop a wound infection and had a prolonged hospitalization as well. And this time I had the advantage of using SAM technology. So I applied PelliShield intraoperatively, and you can see how well this complex wound healed. So this patient, not only did we decrease the chances of the SSI rate for this patient, number 2 is the fact that the wound healed faster, so that way he can get back to receiving adjuvant radiation therapy in a much timely fashion. And once I realized the benefit of this in my complicated wounds, and then I started applying it into more of your regular wounds as well that are more difficult and challenging to heal. This is a patient, again, who has a complex squamous cell cancer that I excised from the elbow that we removed. And again, once the wound healing was happening, we were able to apply the SAM technology as well. And as you're good at something, you inevitably get referred to deal with more complex and complicated cases as well. And this is a patient who actually had a hydronitis of the groin, where we had to do massive debulking, massive debridement as well. And once we did that, you can see all the exposed vessels and so forth. We were able to put the PelliShield on this patient, so that way it can use its technology, get into the nooks and crannies of the wound, apply the silver to the area that you want, so you can decrease the bioburden and the infection for this wound. So that way, eventually, when you do a skin graft, or when you apply a more of a permanent wound dressing to this, then it would heal much better rather than causing failure of graft that you normally see actually. And this is another patient as well that underwent an orthopedic procedure that basically had a shoulder wound that was very hard to heal. So they consulted me to see what we can do for this patient. And again, same thing that we did was my first step always with any wound analysis is apply PelliShield. Apply this matrix in it, let it get into the nook and crannies, let the polymicrobial polymer get into it, the silver, let it do its antimicrobial effects as well. And once the biofilm, the bioavailability of wounds gets better, then we can talk about a skin graft or any other more permanent wound healing actually. And this thing, we just apply it, put a white sponge in it, and then apply your wound vac on top of it, leave it alone for about a week. And then a week later, you can reassess it and maybe reapply it once. But majority of the time, all you need is just one application, and you can see that the wound actually shrinks, heals a lot better. The infection completely goes away, then whatever skin graft that you apply, you're going to have a much, much higher take for it. And because of like my expertise with these wounds, I get consulted on to deal with more chronic, complicated wounds as well. And this is a pediatric burn patient that would undergo almost a bi-weekly dressing changes and application as well. And you can imagine with the pediatric patients, the difficulty of trying to apply a dressing that can cause healing and so forth. And this is a kind of patient that we have actually applied PelleShield on. And unfortunately, at this time, I didn't have the PainGuard. And you could imagine how well the PainGuard will actually work with these patients as well. And even without PainGuard, it's very simple to apply. You just basically lay it out. It's like, causes very, very, very minimal discomfort. And what you see is the fact that you just put a non-adhesive matrix on top of it, and then you apply a dressing on it actually. And this is a patient with a pretty significant second, third degree burn, just a scalding injury actually, that we were able to apply PelleShield in. And as Dr. Pranami mentioned, is the fact that the biggest problem with burns is the graft loss. Imagine the dollars that are spent when you apply a graft and it fails, and then you have to reapply that graft, and on top of it, like even if you use a skin graft, then the loss of the skin graft because the skin graft has failed due to an infection and so forth. So that is why what the PelleShield or SAM technology does is the fact that it optimizes the wound to a much better graft application, so that way you have very minimal loss of the graft itself actually. And because of its rapid application, as you see right here, you just use a nice big 10 by 23 sheet, I believe this is, apply it in there, and you can use multiple applications to cover the whole areas and so forth. And once you do that, you put your non-adhesive dressing, and in a week or two, you can reevaluate, see how it goes, and then they do fantastic actually. So what I've seen is in my application is that I've converted quite a lot of my patients who have had very complicated wounds, who have a higher chance of developing surgical site infections, in decreasing the likelihood of them developing an SSI. And the benefits that I've seen has been tremendous. Number one is the fact that the patients actually look at the wounds and are amazed as to how well it's healing and how quickly it's healing. And more importantly, that's something that we're looking at as well, is the fact that they can get back to receiving adjuvant chemotherapy or adjuvant radiation therapy in a more timely fashion than having to wait for the wound to heal. Because when you have a surgical site infection, unfortunately, when the wound falls apart, now you have to debride the wound, you have to put a wound vac in place, and then you have to wait until the wound completely heals before you can give them chemotherapy, because chemotherapy is counterintuitive for a wound to heal. So you can't really have a wound that's healing and give them chemotherapy and expect the wound to heal. It's not going to work that way. So what you try to do is you try to prevent a wound from falling apart before you can give them any type of treatment as well. And that is where SAM technology has come in tremendously and benefited in my practice and all the other consulting cases that I've been involved with, is the fact that you apply that right away and you see the benefit of the polymeric microbicidal matrix and the fact that it gets to all the nook and cranny, and then it applies the silver to that area, so that way it decreases the risk of infection to that wound. And then you can do whatever you needed to do permanently in terms of either doing a skin graft or a skin substitute placement. So that has been my experience. And now I'd like to turn it over to Dr. Dauphinee, who can talk about his experience utilizing the SAM technology. Dr. Dauphinee.
Thank you, Dr. Sharif. That is a tough act to follow, my friend. Those are some tremendous cases. My name is Damien Dauphinee. I'm a reconstructive foot and ankle surgeon, and I've been using the SAM technology for a couple of years now. Just to go back and look at some of the data, the folks, Manning and his colleagues in 2020 produced a series of 32 patients looking at DFU, diabetic foot ulcers, and VLU, which is venous leg ulcers, managed with standard of care and then using the SAM technology. And these were wounds that had been around for 40 weeks. These were not wounds that were moving forward in any sort of healing trajectory. And they were able to turn these wounds around with the SAM technology, showing that the wounds improved with an average closure of 66% within 3 weeks. We're fortunate if we can get wounds closed by 50% within a 4-week period. In fact, I was part of a study where we looked at the the control groups for some of the major wound healing RCTs. And we found that if you didn't have a wound that was closing by 53% within a 4-week period, it had a 3 to 5% chance of closing within 12 weeks. So it's a very black and white picture. If you can't see a wound moving forward and closing at least 50% within a 4-week period, that's a wound that's not moving in a trajectory that's going to predict wound healing. And in this case, they were able to show the SAM technology allowed 91% of these wounds to close completely or improve significantly within 12 weeks. And they were able to see a 73% average wound area reduction. A case series by Chatelain in 2021. This was using this technology, I think, in a unique way and applying it into the deep portion of the incision prior to closure. And in these cases, these were patients who were diabetic patients. They were significantly at risk for post-op infections, as diabetic patients are because of immunopathy and a lack of growth factors. 100% heal rate in this population, 0 infection rate, 0 adverse effects, no foreign body response to the matrix, which is what you'd expect from this product. Just to talk about some of my own cases, I deal with some really complex Charcot reconstruction. These are diabetic patients who've had catastrophic destruction of joints based on their neuropathy, based on blood flow. You actually get a washing out of the mineral in bone, and it makes the bone very soft, and they can literally have the architecture of the foot fall apart in a very short period of time. This was a 77-year-old diabetic patient who was referred to me for catastrophic dislocations of their ankle and their subtalar joint. So this is the ankle, essentially the bottom right half of this left picture is actually where the toes are. And then as you're looking up, that's the leg. So this patient had a pantalar fusion where we fused the ankle and the subtalar joint and then placed them into an external fixator to provide compression across those fusion sites. And unfortunately, this patient dehisced despite all the best preoperative care we could provide. They had A1C that was in range. They had adequate perfusion. This patient still went on to full thickness dehiscence of both the medial and the lateral ankle wounds. So this is, one of the things you got to roll with the punches with diabetic patients. But we were able to turn this around pretty quickly with the help of hydrosurgical debridement and then using the SAM technology, followed by a brief course of some placental-based allografts. So this was post-op day 7. We clearly had a problem here. We needed to take them back to the OR to do the hydrosurgical debridement. And once we'd accomplished that, we had much better looking wound beds. But these are pretty significant wounds. These are large wounds that are an opportunity for infection every day they're open. So this was when we placed our first piece of the SAM technology called microlate matrix. And you can see these wounds really start to turn around very quickly. So let me just go back one. Nice granular bed, but there's bacteria in this wound bed. There's colonized bacteria. This wound's been open long enough that there's absolutely no chance that there isn't. And that's going to keep this wound open. It's going to make it very difficult for us to graft these. So we've got to clear this. And that's what I think this technology is really exceptional at. We can use it right away. We don't have to wait. And this allowed us to control the bioburden in the wound bed and get these wounds to turn around very quickly. So at this point, after 8 weeks of the weekly application of the SAM technology, we had rapid wound stabilization, and we had a 78% size reduction within 6 weeks. And then we were able to use the placental-based tissues to try to get it to the finish line. But a very big win for this patient. We left them with almost no hardware because of the external fixator. So they didn't have nidus of infection left behind, which is sort of my theory with Charcot reconstruction. We try to leave as little hardware behind as possible because it just ends up being a nidus for infection down the line. And this patient's gone on to healing. They had a tremendous fusion of both the ankle and the subtalar joint, and the only thing lagging behind was the skin. So we had to get that skin envelope closed. I think the newest application here with the PainGuard is really interesting for our patients who have sensation. So I deal with a lot of neuropathic patients who might not need this, but the venous leg ulcer patients, clearly most of them have sensation. These dressing changes and debridements are very uncomfortable for these patients. So we're excited to be able to use this in those patients. And then we're also excited to use this in our incision lines in the patient populations where we'd have the biggest chance of post-op infections and for people who clearly have post-op pain. And we've been very excited about using this. So originally, the SAM PainGuard was provided to 5 separate centers. A number of different surgeons had access to it initially, applied to over 20 patients. I bet that number's like 2 or 3 times the size now, in a range of wound types, including autograft donor sites, surgical sites for bunionectomies, in my case, neurolysis in my case, and one of the surgeons was using it in the wound and the incision for treatment of osteomyelitis. I think that evaluated pain levels at T0, so prior to the application, 45 minutes after the application, and then 3 hours after the application. So this is one of the cases that we used it on. This was a triple nerve decompression in a patient who had rapid weight loss from one of the GLP-1 drugs. They lost about 200 pounds in an 18-month period and developed something called Slimmer's palsy. And Slimmer's palsy is where you lose enough weight that you start to degrade the fat pad around the common perineal nerve at the fibular neck. And those patients can develop drop foot. And this patient developed a bilateral drop foot. They had neuritic pain going down the leg, classic for this distribution of this particular nerve. And they were in big trouble. They were heading down the wrong path. This was a diabetic patient, so we did want the benefit of the silver impregnated in the SAM technology, and then also the benefit of the PainGuard to see if we could limit his need for opioids after the surgery. Typical application is simply applying it right into the wound bed and then suturing our normal suture technique right over this. So this was the superficial fibular nerve site where we used it, and I believe we have a video here showing some of the application here. There we go. Very simple. We cut this into strips. We lined the incision line with this over the deep fascia that was exposed, and we get the benefit of the silver, and we get the benefit of the lidocaine delivering pain relief to the patient. This patient did really well. I think he used his opioids for about 2 days and then was off them very quickly, which would be unique. The surgery, the dissection is pretty extensive in some cases, and these patients are going to have post-op pain. This patient was sensate. His major issue was motor, not sensory, and he did quite well after the surgery and had no adverse effects from the use of the SAM technology with PainGuard. So again, following the PainGuard application, his pain was reduced basically to 0 in less than an hour, and that extended beyond the time frame that you would expect. If 80% of that lidocaine is dumped almost immediately, you would expect that patients would start to have the pain return, and that doesn't seem to be the case. And so I think part of what this product is doing is it's covering over those exposed nerve endings and really getting them to calm down, in addition to delivering the pain relief from the lidocaine. And it's interesting that bunionectomy surgery is actually a very popular acute pain model. The last 10 to 12 drugs that have been approved by the FDA for acute pain have used bunionectomy as their acute pain model. And so it was a great place to try the SAM technology with PainGuard. And we were using this in lapidus bunionectomies. Lapidus bunionectomies are probably the most complex bunionectomy that we do. It involves fusing the first metatarsal cuneiform joint. There's a lot of bone work that goes into that. We're putting a plate with 4 or 5 screws into the bone, and then we're doing an osteotomy at the hallux and putting another screw there. There's a lot of dissection. You can see this incision is pretty long. And so these patients have post-op pain that we clearly typically treat with opioids. Anything that we can do to limit the amount of opioid use and shorten the days to use and the amount that they're needing would be beneficial, because then we don't have to worry about constipation. We don't have to worry about other complications from opioids, including the somnolence. People can get back to driving sooner if it's their left foot that we operate on. If it's their right foot, obviously they're not going to drive for several weeks. But if it's their left foot and they're off the opioids, they can drive, so they can get to and from visits. This patient did extremely well. We never would have expected her to stop her pain medication on post-op day 1. And she literally got off her opioids at post-op day 1 and did not need them subsequent to that. So that's a huge win. This patient never had to worry about constipation or other complications from their opioid use. So we were extremely pleased and excited about using this in our bunionectomy population for both protection against post-op infections. So, diabetic patients, people with immunopathy, they need elective surgery too. And anything we can do to make that elective surgery less problematic for the patient, certainly not involve, admission to the hospital afterwards for complications. That's going to be a benefit to the entire medical community and to the payers. So I think the combination of the silver technology with the PainGuard is really tremendous, and we're excited about being able to use this in all kinds of ways. So the SAM technology is fully synthetic, ultra thin, porous matrix, and it's designed to resorb in a week, which works great for our chronic wound patients because we're typically seeing them weekly. And it conforms to the micro textures of the wound bed. You've seen the videos where it really gets into all the nooks and crannies. We love, all three of us have used that term. That's really the best way to describe it. It's antimicrobial, containing silver at a very low rate that kills bacteria at 99.99% and is non-toxic. The lower the least amount of silver you can use is really the best option because you're not going to hurt keratinocytes. And then now we've got pain relief with PainGuard. So this is really a great combination, and we're excited to see what other stuff they come up with that we can add to the SAM technology in the future. Successfully used in the management of hundreds of chronic and acute wounds, and I think our surgical incision line use is going to be just growing from here. So I want to thank Embed for having us talk about our experience with the SAM technology, and in addition with the PainGuard with lidocaine.
Yes, thank you, Dr. Dauphinee. I'm going to jump in here to say thank you for the excellent presentation to all of our speakers. We'll now open up the discussion to the audience for audience questions. So again, if you have a question for one of our speakers, you can send it using the question submission box on your screen, and we'll try to get to as many as we can in the remaining time, which is about 15 minutes or so. So the first question I have is for Dr. Pranami. In the application of SAM in burn care, is there a limitation of how much can be placed in a large total body surface area percent?
Yes. So I'll just clarify that SAM matrix without lidocaine, there is no limitation, but SAM matrix with PainGuard, it contains lidocaine, and there is a limit on total lidocaine that can be administered over 24 hours, and that is 300 milligrams. So what does that 300 milligram correspond to in terms of the wound surface area? So we have guides, we have tables which inform exactly how many pieces of a given size of the product can be applied to a patient. So the answer is there is a limit to how much PainGuard product can be applied to a wound.
Thank you so much for that response. The second question is for Dr. Dauphinee. Can this product be used in conjunction with negative pressure wound therapy, or NPWD, if a contact layer is used?
Yes, absolutely. Yeah, when you see it interdigitate into all those nooks and crannies, it's doing its job right away. You can put the contact layer over if you need to, and then apply the vac sponge over that whole construct. And I think it's actually going to hold all that material in place nicely, just like we would over a split thickness skin graft. So that's one of the advantages of VAC over or negative pressure wound therapy over that type of technologies. It's going to allow it to do its job, and it's not going to interrupt it.
Excellent, thank you. For the next question, we're going back to Dr. Pranami. Lidocaine has a short half-life. How do you explain the longer than expected pain reduction?
Well, I think Dr. Dauphinee during his talk mentioned briefly that microlight matrix or SAM technology is designed to adhere intimately to the tissue, right? So it conforms to all the nooks and crannies, and it is in intimate contact with the tissue, right? So when it is so we hypothesize that the matrix is in close contact with the open nerve endings. And so when it is doing that, it is able to soothe those nerve endings, resulting in pain relief that lasts beyond the effect of lidocaine. Dr. Dauphinee, if you might want to add anything to that.
That just seems to make the most sense to me. I'm not a bench scientist who can play with all these things, but just as the lowly surgeon, I would say, man, that seems to make the most sense. Anything we do to control, to soothe those nerve endings seems to be helpful. And there are other products that we've found that to be true for, but nothing that has silver and the delivery of lidocaine. So I think this is unique in that it does extend pain relief beyond the half-life of lidocaine, significantly beyond. So even in the elective patients who have perfect sensation and had very complex bone work done, I fully expected using it in the incision line would give them initial pain relief, but then they would need to restart their opioid 2 or 3 days later. And that didn't happen. And it hasn't happened since we started using it.
Thank you both so much. We're going to involve Dr. Sharif in the discussion now. We didn't mean to leave you out. So the next question is for you.
Bye.
Does the SAM product need to be removed?
No, actually, that's the best part about it, because it's a fully synthetic, absorbable. You do not have to remove it, actually. It just basically incorporates into the tissue. And like I said, within a week, it's completely gone, and kind of just, piggybacking off what we talked about from the other questions as well. Yes, I actually do use it for open wounds, and I do put a wound vac on it, actually. So wound vac is definitely very, very applicable for these patients as well, actually. So for all kinds of classifications of wound, we use it on clean wounds, obviously, contaminated wounds as well. So once you kind of clean them up and debride as much as you can, you could just place this SAM technology microlight on top of it, actually, put a wound vac on top of it, and just kind of leave it alone. And in a week, you will see the benefits of it, actually, because, again, we keep using the word nook and cranny. It seems like, we've reversed it, but trust me, we have not, but it's just that it describes it very well about how well it works. Again, going to the PainGuard as well, when you make an incision, obviously, you're causing damage to the nerves, endings, and so forth. And those nerve endings is what causes the pain. And until those nerve endings kind of get blunted, that's when your pain gets better. We have systemic ways of treating nerve pain and all that other stuff. But even if you apply any kind of dressings or any kind of like local injections and so forth, how do you know it's getting into the nerve endings, right? That's the problem, right? That's the reason why postoperatively patients have pain. I do pain blocks on all my patients who have abdominal incisions and so forth. But if you can get the lidocaine or any kind of anesthetic to the nerve endings itself, then that's when you're going to get the most benefit out of it. And that's the benefit of the SAM technology, is that it incorporates so well to the tissue because it's like such a nice thin layer that you get the added benefit of pain control as well, besides the antimicrobial benefit as well. So yes.
Thank you. That's great information. And the next question is for you as well. So following on to that a little bit, can SAM be used on donor sites for skin grafting?
Yes, 100%. And I think that's one of the main benefits of it too, because the donor sites, if anything, probably hurts more because those are almost kind of like your skin graft, like just almost a shearing effect of it, actually, so those areas for donor sites are painful, and especially with PainGuard technology, I think those would be fantastic to use in those wounds, actually, for it to heal completely and for very good pain control as well. So yes, 100%.
Wonderful. Thank you. And more questions coming in just now, kind of following on for some more application type questions for you, Dr. Sharif. What about using it in sternal closure?
Sternal closure? Again, that's one of the things as well, as someone who does very complex procedures and does a lot of procedures of other types as well. When I see the benefit in one, then why would you keep it away from it from other patients as well who can benefit from it, right? So my practice right now is any scar incision that I make, I apply SAM technology to it. And hopefully I can, get the PainGuard as well. So I can start utilizing that as well as a form of local pain control too. Meaning that any wound that I see, I place my SAM technology to it. So definitely will be very beneficial for your sternal wounds, for cardiothoracic surgeons. I even use it for my esophagectomies when I have to do a thoracotomy, and I put them on the thoracotomy scar itself, actually. Some of these things hopefully can alleviate other types of pain control that we use, like a pain block or like doing like regional blocks as well and so forth, because now you can directly apply a mechanism for pain control to the wound that is causing the pain itself, actually. So yes, we can use it in all types of wounds.
Excellent. Thank you. The next question, I think maybe a combination of yourself and Dr. Dauphinee could respond. Again, just some more application type questions.
Yeah.
One of the audience members asked, could the SAM technology be used with chronic wounds with tunnels and extensive undermining?
I don't see any reason why not. I think there's always the little trick of, with a tunneling wound, how do you allow something that's going to quickly change its shape when it hits moisture to stay intact enough to get into the wound? And so we've done some tricks where we've put it around other products that are going to absorb as well. And so one of those would be basically a methylcellulose or a cellulose product that's going to dissolve. And you can use that like a core, wrap things like the SAM technology around that, and then plug that into your tunneling wound, so that the SAM technology is pushed up against the walls of the wound bed where it's going to do its most good. So we haven't had a chance to try that yet, but that's what we've used other products that are similar in that they're delivering antibiotic material to the wound bed. I don't think there's anything out there that's truly competing with this, with regard to the fact that there's no animal products involved in this. We don't have to worry about anybody having, as far as we know, any sort of hypersensitivity to any of this material, which is not the case with the products that have animal components in them. But yeah, I think there's you have to get creative, but I think there's some creative ways that you could use this in tunneling wounds that would be really dramatic, and I think could help.
Yep, exactly. Just piggybacking again off with Dr. Dauphinee. Yeah, I think I showed you one of those pictures about like patients who have had those hydronitis as well and so forth, that you have a lot of these exposed tendons, wounds, vessels and so forth, that you can use them in order to be able to get into or incorporate into any of those topographies that are not just your straight like in a very smooth topography itself, right? So yeah, we use it, and honestly, like Dr. Dauphinee mentioned, I've actually used him in fistulas. When you have fistulas that you're talking about anorectal fistulas, or even talking about abdominal intracutaneous fistulas, we put G tubes in or J tubes in, and once we take it out, then you have that wounds that don't heal well, and sometimes you can have those wounds that have a little bit of drainage as well. I have actually, like we said, roll up the microlite actually and just kind of stuff it in there, So because the biggest problems why fistulas or wounds don't heal is infection, right? Like, when you have a persistent source of infection, it's never going to heal. And the problem is, it's like, how do you get to that infection, to get rid of the infection, besides doing a major procedure and kind of completely debriding it and so forth? This is much simpler. You can do it in the office or do it under local anesthetic, as well as just use the microlite, just roll it up and then just push it back inside it. So that way, let the silver do its work where it's supposed to from its antimicrobial effect. And at the same time, because it's a bioresorbable, it resolves as well. So that way you don't have to worry about leaving a foreign body into it, and see if that works. And then before moving on to it as well. For the few cases that I have done it, actually, I've seen the fact that by just applying this itself, that it gets rid of the infection and gives time for the body to heal itself, actually, And again, we're talking about patients who are not immunocompromised, immunosuppressed as well, and then have their own immune system that lets the healing healing process, as long as you can address the underlying infection with the SAM technology for it, actually. So yes, I have used it, and it's been very, very beneficial.
Thank you, speakers, for this great discussion, and to the audience for sending in these wonderful questions. I think we have time for maybe one or two more before we have to break. The next question is for Dr. Sharif. Can SAM be applied in a bedside or outpatient setting, and can it be applied by a wound care nurse?
Oh, absolutely. As you saw, it's very simple. It comes in obviously a sterile package. You open the package, you cut into the size of your wound and just basically apply it. Honestly, you see it once and then you can see how easy it is and you can actually apply it. So yeah, it can be used in the office setting. It can be used in any setting that you have, actually. And yeah, no problem at all. I just applied firsthand only in the operating room, only because I'm there anyway. I'm have a wound that I know it's going to potentially have a risk of falling apart. So why don't I do something prophylactically before the wound falls apart to decrease it from falling apart, actually, and then, like I said, again, because I do get referred for all those chronic wounds as well. I do see them in the office. If I have that product in the office, then yes, I apply it first and let it heal and see how it does before maybe taking them if they need any additional debridement to the operating room. So it could be done in any clinical setting, and it could be done basically by anybody. Even an MA can do it as well, honestly.
That's great news. Thank you. And I think that's about all the questions we have coming in, and we're just about at time anyway. So I'm going to close us out for the day. Again, we thank Embed Biosciences for sponsoring today's presentation. Thank you to our attendees for your attention. And thank you to our excellent speakers. That was a wonderful presentation, very informative. We hope you all enjoy the rest of your day.
Very good. Thank you.
Bye-bye.